welcome everyone. Welcome to the Michael Ratner Memorial Lecture Series. I'm so glad to see, not quite a full house, but almost. It's ugly weather out there, so thank you all for coming. I'm Terry Ratner. I'm a registered nurse and a freelance writer who has hosted the MRM Lecture Series for the past 9 years. It'll be 10 years actually in February. I began this series when my late husband, Michael, was diagnosed with cancer in 2008. We pride ourselves in finding the most innovative experts in specific health-related fields to share their wisdom and their philosophies with the community. I'd like to take a moment and thank a few of our sponsors. Journey Care, a nonprofit, community-based organization delivering palliative, supportive, and end-of-life care across 16 counties in the Chicago area and northern Illinois. Comfort Keepers, a leading provider of quality in-home senior care in Chicago. Of course, the Skokie Theater for their wonderful space. And Michael Bidwell, owner of the Arizona Cardinals, who has generously supported us for the past 8 years. Tonight, I'm proud to present Dr. Martha Twaddle, who has nearly 30 years of experience in the care of seriously ill patients and their families, and her cancer patient, Pamela Holtzman, a hospice RN and licensed clinical social worker. Pamela first interfaced with Dr. Twaddle through her work at the Cancer Wellness Center and at Midwest Care Center. Martha says, Pamela, an individual who radiates vitality and kindness, allows me to be her true colleague and companion during this journey. Our partnership embodies the concept of shared decision-making. Our relationship is about trust. Dr. Twaddle currently serves as the medical director for palliative medicine and supportive care at Northwestern Lake Forest Hospital. Her academic work includes developing curriculum guidelines to facilitate the training of healthcare professionals in home-based primary care. Boy, do we need that. What baffles me is the way many healthcare workers dodge the idea of palliative care for their patients who would benefit from it during the early stages of their illness. My experience is how the word palliative, when it's mentioned to a healthcare professional, often produces a weird response, as if it's a concept not quite understood, a foreign word without a clear meaning, something that isn't necessary or beneficial for a patient, a topic they prefer not to discuss, a subject that makes them uncomfortable. I recently visited a patient at Northwestern Hospital in his 90s. He was diagnosed with lung cancer, complicated by COPD, recent pneumonia, and blood pressure problems. The professionals talked about invasive procedures like thoracentesis, a bronchoscopy, but never brought up the subject of palliative or hospice care. The topic seems to be ignored until it can no longer be avoided when the patient is dying. I'm a strong believer in both palliative and hospice care before it is too late to serve its intended purpose. I know that you'll all have some questions for our presenters, so we will have a Q&A at the end of the event, followed by a meet and greet. So without further ado, I'd like to introduce Dr. Twaddle and Pamela Holtzman to begin our presentation, The Secret of Living with Cancer, Partners in Palliative Care.
Good evening. This is quite a wonderful turnout. It's good to be with you all. Mm-hmm. So before we start in our little fireside chats, we just want to acknowledge and share gratitude for Terry and this amazing lecture series. Very remarkable, very brave woman, and great inspiration for this series. So my beloved Pamela and I have our notes. I'll take my glasses off periodically. Okay. So we were going to start off talk a little bit about what is palliative care, as Terry kind of launched us, and talk big picture, but then share our story. So as you probably know, palliative care is team-based medical, team-based care for people with serious illness. And it helps to navigate the symptom management, and it helps especially to reduce the stress of living with serious illness. It's to me, having been in this field now 30 years, having the privilege of watching this field emerge, what I recognize is it's about just good medicine. It's about what medicine was intended to be, which is taking care of people, getting to know people, body, mind, and spirit. And it is, to me, the renaissance of medicine. So I trained as a primary care internist, but even as chief residue, as I called myself back in the day, at Northwestern, I was introduced to the world of hospice care, which was the catalyst of bringing palliative medicine to the United States. And as I said, I've had the privilege of watching this field emerge over the past 16 years, becoming a specialty in 2006, and a recognized catalyst for healthcare reform. So, what else should we talk about with palliative care?
Well, I heard something that I thought was really interesting, and it had to do with the difference between traditional medicine and palliative care.
Mm-hmm.
And they said traditional medicine is like service, and palliative care is like being a host. So in service, they have a product, a menu of treatments, of how, and the only palliative care might be how to treat the symptoms that they cause by those cures or treatments. And palliative care kind of greets you at the door and says, how can I help?
Mm-hmm.
Where is your suffering?
Mm-hmm.
What can I do? And there's such a difference in the relationship as a patient when you're received in that way.
Yeah. So traditional medicine is based on disease, diagnosing and treating, starting from the idea of what's wrong with you and how can I fix it, which isn't not possible, right? We don't fix things. Whereas palliative care is about who are you? Tell me your story. What's most important to you? How do you make decisions? What is suffering? And then coming alongside, because it takes a team. This isn't a medical model. This is an interdisciplinary team to better understand the perspective of an individual who is seriously ill.
Correct. You do that very well.
So maybe you could tell your story, and I'll add to it. Because it's our story.
It's our story, for sure. Well, I'll begin with a part of a poem by T.S. Eliot that I just was so moved by. I burst into tears when I first heard it. And he said, after all the adventures and the excitement in my life, I find myself exactly where I started, but I see things for the very first time. So I think about that, sitting here with metastatic breast cancer caused by a cancer that I had over 40 years ago when I was 23. And it's a very different perspective. Because at 23, I showed up newly married, a brand new baby, a new home, my whole life ahead of me. I had a lot of, I didn't have a lot of resources. I had a lot of reserves, but not a lot of resources. So what I showed up with, you'll laugh, this is typical of me. I had like a phone book of a home study from the Academy of Guided Imagery from Santa Barbara, California, and a big box of CDs. And I immersed myself in that during my treatment. So I would show up to them and I'd say, look, you just need to tell me what you're gonna do. Tell me what's gonna happen, what you're gonna do, and I'll prepare to greet you to optimize the treatment, to make it as best as it can be. And the few times that they didn't do that, it wasn't pretty. It wasn't pretty at all. So I didn't know quite then, but it was kind of naturally, I had to be a part of something. I couldn't just be done to.
Yeah.
And you know, in the middle of the 70s, cancer treatment, oncology was still pretty primitive. So in those days, they just had really big guns. Here I am, 23 years old, Non-Hodgkin stage 4 lymphoma. So it's pretty much a death sentence in those days. And the first thing they did was full mantle radiation, which is what caused the cancer. But 40 years later, you know, I actually just felt lucky. First, I didn't know that it was going to cause cancer, so I wasn't living for 40 years worried it was going to cause. I think that sometimes is a blessing. And second of all, I had 40 years. So I didn't take it hard that way. But that didn't work, the radiation. So then they used a clinical trial of the most caustic, aggressive chemo agents that they had available to them that they said, we'll either cure you or kill you. And it darn near killed me. I went down to 98 pounds. And when they were done with their protocol, they had nothing more for me. In those days, there was no healthy lifestyle paths to wellness for survivors. They didn't have anything. They kind of kicked me to the curb to survive. And hopefully I would do that. And quite frankly, in those days, not many were. Most of my peers and colleagues were not. So I'm, you know, I have like dismantled. I have no life force energy. I've got nothing. Everything that I thought was true was no longer. And I started like crawling my way back into health. Beginning with just eating. Because at that point, I didn't want anything to do with food. I wasn't interested. We had a friend who was a macrobiotic, and he taught us how to ground brown grains and grind it and mix it with water. And like a baby, make like a gruel. That slowly I could take some nourishment and then begin to have whole foods again. So that was the beginning of my pretty healthy relationship with foods. Started then where I listened to my body, what I could receive and what worked for me, and continued that on. But then I still was, there was nothing to me, so I needed my strength back. I wanted not just to survive, I wanted to thrive. So I had loved swimming as a child, so I'm very disciplined. So I made myself get in the pool 4 times a week, go to the Y for 30 minutes. I didn't care what I did. I had to be in the pool. Of course, I was 98 pounds, so I'd freeze if I didn't move. So, yeah, I started to move and eventually got stronger. And then I started walking and swimming, brought my yoga back. In the last 10 years, we started doing something called Qigong, which has been life-giving. It's a medical martial art that uses the body's chi and pressure points with the sole purpose of healing. And quite frankly, I used it after my mastectomy, got full range of motions very quickly back. They were amazed without any physical therapy. And it just keeps everything moving, and it definitely increases life force. So that was a gift. Okay, so now I'm stronger, but you know, everything had been stripped away, and I couldn't make sense of what happened to me. I needed some meaning. So I went back to an interest in, I think I was like 17, I'd taken a course in Buddhism. And I was very intrigued by the teachings and the practices and the philosophies and the psychology of Buddhism. And I became a student, and that's where I learned to meditate. And it was really a beautiful way to kind of get me back in life and teach me how I wanted to be in the world and use those practices. So I still was feeling better, but I didn't have any purpose. Why had I survived? I didn't get that. So I was very drawn. That's when I was drawn to go back to school to become a hospice nurse. And I did that for 10 years. It was quite a privilege, and I sat with so many good souls. And I learned 2 really important things, and you know these. One is not to be afraid, not to be afraid of death. And the other is that a good death is directly related to a good life. And that was my motivator to live the rest of my life being the best that I could be. And we did that as a family. So we lived by making today count, by embracing each moment with gratitude, and living without regret. The best example of that was when we built our house in the Bahamas right after 9/11. I remember my daughter, my husband, and I sitting on the beach saying, "Are we crazy? This might be it. And it might be the smartest thing we ever did," and it was. That became our healing place. And that is where we went. That's where I was when I developed the tumor on my breast. And I knew it was cancer. And so before I even went back to have that confirmed, I was real clear that I was only going to do the intervention of, if they thought so, surgery, but nothing more. That my body at this point is fragile. It's tired. And I know it very well. And it couldn't take the aggressive, it would kill me. I was so clear about that my husband would actually hold me back. I'd walk into a doctor's office, "I'm not doing anything." Like, just listen.
Let him talk.
But I was so passionate, I was kind of scared, in a way.
Vulnerable.
Very vulnerable, for sure.
Yeah.
So we went back, and the first thing I did was started weekly acupuncture and called Martha. You remember? And I called Martha, we had a lovely conversation, and I said, "I hope I never need to use you." But, as teachers together and healers and practitioners, I might need someone to do that for me. And I couldn't think of anybody better. So thank God you said yes. So then we thought we were done with it, right? I'd done the surgery, I got through it, and we planned a dream vacation. And we decided that we were going to take a month in Sri Lanka. Sri Lanka is a Buddhist country, a beautiful country. It seemed very healing. And the first 10 days that we were there, we were going to an Ayurvedic clinic, because I've always liked alternative medicines, and it was an opportunity to really heal from the trauma that we'd been through. Well, it was there that the Ayurvedic doctor discovered the tumor, right where the mother, I called the first one's the mother,
And
the
the
second one was a
juvenile
mother
delinquents.
too, and right in exactly the same place. So the incredible part of that was we had a month in Sri Lanka, and we knew what we were dealing with. So we had all this time to do a life review, to grieve, to plan, and to get on the same page together. So we are a team in this. We have cancer. As a family, we are very open about everything. My family supports me and my decisions. They're not shocked. The fact that when I came back, I'm not doing any other treatment except management. So that is when I reached out. Well, I did two things again. I immediately got a license for medical marijuana, or at least got on board on that. And then I talked to Martha. And that's when we began our journey.
So Pamela and I have known each other as professionals since I was an internist. Yeah, since, referring to the Cancer Wellness Center. And when I ran the fellowship program for Rush, I incorporated the Cancer Wellness Center as a place of learning for the fellows. I felt it was really important that they experience that community environment. So she's been my professional associate for a long time. And a woman I always experienced as one of those wow energies that walked in the room. The room would light up when Pamela would walk in. Still does. So what an honor. What a profound experience. I'll probably get verklempt,
Okay.
To be asked to be involved in the care of someone I hold in such esteem, and who's also been a teacher for me and a true colleague. And I think that idea of partnership. So we've talked a lot about, what we do for each other. I have always looked at my role as a physician as the perpetual student. My teachers are my patients. And I say that to my students, your teachers are the people whose robes open in the back, who live the illnesses in aggregate that you study on the pages. Because you study things in linear sequence, and they live it all at the same time. And in today's world, particularly as people live longer and live longer with chronic illness and live longer with chronic illness that limits them physically, it's a different journey. So what we have enjoyed as colleagues in this journey is really this idea of shared learning. Because we don't know, goodness, it's been amazing. She looks fantastic. Yeah. We don't know what the turn in the corner is going to bring. You know, people write their own story. When you're confronted with a serious illness, you're going to write your own story. The studies, the population-based, randomized, double-blinded crossover trials are only good in looking at populations and looking at interventions, but they don't tell me or any doctor about you or me or Pamela. They give us an idea of what we should look out for, but they don't tell me what the future holds. And I look at it as a switchback trail. Sometimes the corner is 270 degrees and I can't see around it. But we know what we're going to do to walk the journey. And we're going to listen to each other and we're going to figure out what's most important, what are the trade-offs, what's the worst case scenario, what's the best. What do we want to set our intention for as we prepare for what could happen? To me, that is the essence of good medical care, and that is palliative care.
Yeah.
So what we realized is we exemplify this thing called shared decision making. We could go on a tour.
Take it tomorrow. But you have to be at work tomorrow.
That's right. That this idea that certainly I might have medical knowledge and I can explain an illness, I can explain what the medications, the pros and cons, the burden and benefit, but Pamela will live it. And she's got to give me the feedback of what that would look like. And you said it so well in one of our conversations, what it's like when we make decisions together about treatment. Do you remember what it is you said?
I don't remember that specifically, but I can tell you this, that having alignment with you just literally makes me feel safe. I don't feel alone. I would be scared. I'm not scared. I got Martha. You know, it's going to be what it's going to be, but it's not alone, and this is a huge, is that what I said?
Yeah.
Is that what I said? Oh,
well,
good.
but it's good to hear it again.
Okay.
And it's different. It's, you know, it's an incredible affirmation. And it is, you know, I think what people don't realize is that physicians, too, sometimes are a little bit scared because we don't know what's going to happen.
Right.
And you can imagine there's a tremendous amount of love in this relationship. So there's a vulnerability for me as a doctor that's a little bit unique because I'm caring for someone who I've known for a long time. So this sense of shared, we're going to do this together, is really better for the whole relationship. It's healthier for the treating physician, and it's healthier for the person receiving the care. So the more we can advocate for that kind of relationship, it's not easy. It takes some ferocity, I think, and strength of character to say, this is what I need. And also a family like Pamela's blessed to have that comes with her to the appointments and can give that additional perspective and be part of the care and share in the decisions.
I'd like to throw something in there about families, too, because being the caring professional myself, I realize that a lot of times people protect their families when they're going through something. And this is a very lonely experience, and we don't know where it's going. And that includes your family. So you're setting kind of an example of how we're going to do this, you know, to your family. So if you dare to be brave enough to talk about what's going on, and sometimes I'm like, is that too much? Or I feel like I'm complaining, and I need a little feedback. I'm like, or yeah, I told you, or no, you need to do that, you know. But we're in it together, and that's really important. And people just don't do that. At the end of if someone dies, then their family is left with all that wasn't said.
Yeah.
And you have so many opportunities, like the time in Sri Lanka, and from that moment forward, where the conversations are open, it's just, you can't make those up.
So Pamela and I have used some unique ways of communicating.
Yes, we have.
And one of the things that we've done, and this isn't an ad, I don't have any financial kickback for saying this, but we use an app called TapCloud, which is a telehealth app. And it has been fabulous. It was created by a gentleman named Tom Riley when he was caring for his mother, who was very ill, and it captures the experience of illness. It's all encrypted, de-identified, highly secure. And you can report on how you're doing. You can send me photographs of the mother and the juvenile delinquents. And we then can do secure web-based conversations when she's in the Bahamas.
It's amazing.
So this allows us to stay connected through this journey together, and for me to have a sense of how things are going. Because I think about her when she's not in front of me, and I want to know how things are going.
It's kind of like a medical journal, too, because I can access like charts of what my pain was like or what I was reporting. So it gives a lot of pain level. And then adjectives, you know, are you calm? Are you, is the tumor a problem? You know, just different things. So you highlight or red light if it's, so she'll know right away I'm having trouble breathing for a while. And that I don't have to call her or do anything else. So she, all of a sudden I get an email like, you need to da-da-da.
I'm watching you.
Yeah, she is. It's really good.
And that probably contributes to that sense of
Safety.
having your back and feeling
Right.
safe.
Right.
Is that it's not all up to us when we're not feeling our best or when something's happening, to know that there are people that are watching, that are paying attention, that are leaning in, that are really listening. So that allows us to relax a bit in it and feel like we're taken care of.
And that part two of that being a burden, you can tell I got a little stuff around this. You know, I'm a caregiver, so I feel real comfortable doing that. And a lot of people in this room probably understand what I'm talking about. But to be the recipient of that attention can be very uncomfortable. And I had to learn that a long time ago, that it's okay. And the way I learned that, by the way, I don't think I ever told you this, was to imagine that I'm just a vessel. And that love, which it is, of caring, is just pouring through me and filling up the areas where I may be a little bit low in reserve. So when it's my turn and I'm, you know, able, I have abundance to fill back. So I never felt like it's too much, like it's, you know, a dam in there. It's just a free flowing of loving and caring. So that's how I dealt with that. That's a little side story. I want to tell a story on you about how you got me to Emory.
Oh, yeah, okay.
That's a good story. So I'm in the islands, and I was having a bad run, and I started getting in my head, which I try very hard not to do, and I was scared. Like, what if this gets worse? What are we going to do? You know, and you have to know that after the mastectomy, I was so, like, nothing more. I never had any tests. I never had any scans. We had no idea what was going on. My cancer's all visible outside on the skin and the tumor. So and we were trying to sell our house and move to be with our family in Atlanta. She knew that. So Martha, in her way, said, you know, I have a really good friend who's head of palliative care in Atlanta. Maybe you should just meet her. So I did. I met Tammy Quest, the head of palliative care at Emory. Lovely, wonderful lady. And she said, now I don't know if you guys were colluding about maybe. Now the truth
it was the
comes
same
out.
thing, the exchange, the
Yes.
thoughts. You know, what's wonderful in palliative care as it's grown is there's people all over the world now. And what was really important to me in that time is, again, that this idea of preventing suffering, responding and preventing suffering. And knowing that Atlanta might be a place where Pamela would be at the end of your life, I wanted you to start early to build a team of competent people who you weren't meeting for the first time when you were tremendously in distress.
Exactly.
So
Brilliant.
the wonderful thing is I have incredible colleagues in Atlanta. You know, I've got colleagues in Tel Aviv. I've got colleagues in, you know, Saudi Arabia, actually Dubai. One of my fellows is practicing in Dubai. It's a new day in terms of this incredible network of people who ascribe to this discipline. So I wanted Pamela to meet Tammy, and I needed her also to meet Tammy. So again, this idea of this is almost, it's a mutual journey. I needed Tammy's thoughts, and you can describe Tammy. She's a pistol. She's the head of the emergency medicine initially, and then palliative medicine at Emory. And she'll be president of the American Academy next year. She is an amazing lady.
I've already told her she's mine if I ever moved. She said, well, I don't leave great people. No.
No, you're going to take care of
But
it.
so the end of the story is that it has a happy ending because I had refused tests or any kinds of scans, so I really didn't know what was going on. And having these kind of moving pains and really, I didn't know what was going on. She had, and Martha both were of the mind that if there was something in the bone or the brain that maybe we could do certain treatments that would keep it from getting more, except that non-cancer related. So that's, I bought that. And I'd also had a year of living with it. My fear was, honestly, if we went there and it was there, I would get sick fast. You know, how they give you information, but I felt ready to handle whatever they had to, whatever it showed. Good news is the scans were all clear. I only have metastatic,
locally aggressive disease.
Aggressive disease. I can live with that.
So what it really brings forth is that palliative medicine and supportive care isn't about not doing anything. It's about, everything's about doing what helps you live well, what helps you thrive, what helps you to have wellness and lack of distress, even in the face of advanced illness. So we needed this information. And I found it somewhat comical that I'm the one talking you into disease-modifying treatment as the palliative care physician to say, you know, let's give this a trial to see if this is an option for us, to see if this would quiet some of the symptoms, slow the progression of disease, and help you live well. Because now we know it's just here. So it's going to be a real pain in the patootie, but it's not necessarily going to shorten your life. It's just going to potentially impact the way you get to live your life. So it's worth a try to see if we can modify that through treatment.
So let's talk about pain.
Let's talk about pain.
Let's talk about pain.
So Pamela's taught me a lot about pain because, well, reinforce lessons. So palliative care does a lot about symptom management, and pain is a big symptom, of course, for people with serious illness, particularly those with cancer. Pain is not a physical symptom by itself. You know, Dame Saunders, who's the person who started a modern hospice movement, was the first to describe what is called total pain, which is body, mind, and spirit. So the social ramifications of pain, the psychological, and in our world, the financial ramifications of pain, certainly along with the physical and the spiritual. What does that pain mean? How does it impact your living? So as we've worked together to change the experience of pain, it has really been with that paradigm around us, understanding that pain is more than the physical, and we have to balance these treatments. And what's been wonderfully exciting for me has been to explore non-traditional ways of treating pain. So one of those is medical marijuana. There's a wonderful book I'd encourage you to read called Stoned, which is by David Casseret, Dr. David Casseret, who is now at Duke. He was at University of Pennsylvania. He wrote the book with the idea that he would refute the benefits of medical marijuana and became quite an advocate. Now, there's not a lot of research, but what we do know is cannabidiol in particular is a powerful anti-inflammatory. THC in combination can help with some of the symptoms of fatigue and nausea, can help with pain. Appetite in particular, that's the exploration of THC, particularly after the AIDS epidemic or during the AIDS epidemic is where we got a lot of experience with that. There's one commercial form of these combination called Marinol, I can't say it, Marinol. The problem is it's way too high in THC, and THC is the component that often causes the dysphoria or euphoria. You have to be sure that the combination is right for the person. And one of the things that we learned together was we were using one edible that had THC and cannabidiol, and the tumor was growing. Remember that? So I called up David and I said, does THC have an estrogen-like effect? He goes, oh yeah, think of man boobs, sorry. When people were really smoking a lot of marijuana, they would get breasts. So THC is an estrogen, stimulates estrogen-like effects. So we had to trot back into that dispensary. I don't prescribe marijuana. I give permission for Pamela to go into the dispensary and access it for the condition that she has. And we work with the person, the pharmacist, who is so knowledgeable to help us have the right combination to lower the THC and push up that cannabidiol so that we can get the best effect. So tell us how you're using those medications.
Well, absolutely. Medical marijuana, or probably marijuana, is an amazing pain control. Amazing. It really can keep the pain level down. A couple of things that I've learned is it has a very fast half-life. So I was having terrible problems with calling Martha consistently at nighttime, about 1 o'clock, waking up with like rockin' pain, like just out of, and it took
it
a
didn't
lot.
last.
Because I didn't know. And so I went my Facebook friends that are marijuana users or medical marijuana users, and they enlightened me. So now I just keep one by the bed. So in the middle of the night when I go to the bathroom, I just take that, and that kind of carries it through. It absolutely worked. That was the problem with that. I do edibles. They're like chocolate or candy or a little lozenge that looks like those little blue things that we used to use for mouthwash that you put in your mouth. That doesn't have sugar in it, because I started taking these at night. I'm like, ooh, I'm daughter of a dentist, and I'm worried about my teeth at this point. That's very healthy. I think vanity is healthy at this point, at any level. So I do that, and also some oil, which has just pure CBD. So I basically do some THC, which enhances the CBD, the cannabidiol, but the CBD is primary. So I have little candies and little all kinds of things so I can take them throughout the day. The trick for me is that the minute I start feeling some discomfort, I need to take my medicine.
Yeah.
I cannot wait. It's going down or going up. Something's going to change, and I'm not. It's going to take a lot more. So that's been the key in terms of management. But like you said, it's not well documented. I encourage. I keep pointing over here, the head of the dispensary who is here, Joe, to have like let's do a support group for us to talk to each other and teach each other what's working and what's not working. I stood there to buy my medication, and the guy next to me is like, I'm off all my medications for anxiety. You know, don't take anything anymore, just using this. More and more, you're hearing those kind of testimonies. But it's because of the government and because of the way it's controlled. We need more research. We need more research,
definitely.
For sure.
Yeah.
But it's been a blessing for Bayan.
Well, and again, the anti-inflammatory effect, the effect even of the oil topically, and what Pamela is speaking to is, particularly with pain, it's a constant.
Right.
And people shouldn't have to earn their medication when they're dealing with chronic persistent pain. You have to stay on top of it, and it actually takes less medication to keep it under wraps, to keep it controlled, than to do the back and forth. And the up and down experience of uncontrolled pain relief typically exhausts an individual. It's like a leaky bucket.
Right.
So staying on top of this symptom, figuring out how we're going to treat nighttime pain was our next challenge.
So you came up with that compound, which was freaking brilliant and really helped. I love this. So you want to tell them what that is?
So I work with innovative people, a compounding pharmacist who's actually in Paxton, Illinois. His name is Doug Higgins. And Doug will make special concoctions. We talk about what the pain situation is, what I think are the different drivers of the pain, neuropathic, cutaneous, nociceptive. There's all these different mechanisms, inflammatory aspects. And we will try a combination that he'll put into a cream, and then you apply. And that was pretty miraculous.
That was instant. And then you came up with the idea of adding the THC oil, which topically, first makes it easier just to apply it. And now I've actually been not using it as strong with Sudra because it's expensive, and I add China gel, which is something you can buy from Amazon, with that and the THC. So kind of, this is so beautiful because you can experiment. What's worked for me? This feedback is, I feel better.
Well, and not only that, as strange as it sounds, the blessing is the tumor is cutaneous and we can see how it responds.
Right.
And some days it can be angrier than heck. And other times when we've got the pain under better control, we can literally see the tumor quiet. We can see the dark, the redness retreat, and we know we're on top of it.
I feel very fortunate for that.
Yeah.
And really, it's to be able to monitor so closely is really unique.
So we have added a conventional opioid, and there's certainly a lot of, it's a tough time in the world of opioids right now. We're in a strange, and I've watched the pendulum swing in my career. We went through the cancer pain initiatives and prescribing opioids for everything, and now the pendulum, unfortunately, is swinging too far in the other direction where we're so averse to opioids. So the thoughtful application of using medications that mimic our endorphins and enkephalins through prescription is really, really important. And because this is a mixed pain syndrome that involves nerves and tissues, et cetera, methadone is the best medication. And the tiny amount that you use.
She's talking about oral now. I do this at night.
But it's a drop. We don't need much because we're going after the pain through many different mechanisms. And again, this is the learning and the joy of working with my colleague here is this, I'm the student as well as the doctor. I'm learning, let's try this. What would happen if we added this? And watching together and reporting and using our telehealth to see that things are working.
So there's other ways too that I work with pain. I think probably the first thing I do is treat it through chemistry, through the medical marijuana, so I get that on board. But then I have to deal with me. And there's a lot, I am a person who meditates, so I am able to focus and observe objectively what's not only going on in my body, but what's going on in my thoughts. So if I'm on, I call it chutes and ladders. So if I'm on one of those pain chutes for days and I'm not sleeping well and I'm crying in my pillow feeling real sorry for myself, I'm watching my thoughts like taking me down. So I am very vigilant with my thoughts. If we knew how powerful our thoughts were, we would never have another negative thought. And I'm a person that had read the phone book on visualization in your body, so I know how strong it is. So I'm very careful to observe. I honor sadness and I honor my grief. I don't try to push it down, but I don't want to live there. I don't want to dig a metropolitan of misery in that place. So I have to shift it. And think of something to be grateful for. Think of something that's good about it. Yesterday it was an 8. It's only a 6 now, something. To try to pull away from negativity and feeling sorry, because that is a form of suffering that does not help. There's so many ways that we contribute to the pain, that like worrying or obsessing. Those are thoughts, right? And we can dig ourselves down into these places and we can't get out. We feel helpless, more vulnerable, and more pain. So I work very, very vigilantly with my thoughts. I've told somebody once it took me my lifetime to lose my mind. Doing pretty good, I think.
But we know that mindfulness work and meditation, it is real. Right. That ability to develop the metacognition to watch oneself, and I love what you say about honoring the negative, honoring the grief, because each, when it first showed up, there was grief. When it showed up again, doggone it, when the mother bled, there's grief in this, and you have to honor that, and then set your intention and utilize the meditation. The other potent piece, because you talk about rumination, is nature. So one of the things on Tap Cloud for you is putting your feet in the ocean. But there is powerful research that 40 minutes twice a week in green space is powerfully effective for rumination, depression, and anxiety. Not with your headphones on. Not talking on the phone to your friend, because it doesn't matter then that you're in green space. But actually immersing yourself in nature, smelling, listening, feeling, being fully present. This is called biophilia or prescriptive nature. There's an incredible book by Florence Williams called The Nature Fix. And so my particular research interest is the impact of green space, prescriptive nature on wellness and survival. And I'm fortunate to work in Lake Forest, where we plan to do some studies comparing treatment for those who have access to green space versus Streeterville, where it's an urban jungle. And I think then it will compel us to take better care of the people who live in urban jungles, which is what's happening in Japan and other countries where they're really being intentional about improving the access to nature and to green space.
Or blue space under
Blue space, but green being nature. Just in your case, it's the water, the ocean, and that being a really positive impact. And it's always fun when we do our web chats, and Pamela's on the porch. I'm in Chicago and it's snowing. and I can imagine what it's like to be there. Let me hear.
There's a couple that absolutely nature is key, because you can heal there in that space. And it teaches us so much. But there's two mental constructs, or maybe more, but that I think have helped me very, very much, and I wanted to make sure I share these. And one is that I only deal with what I know to be true. So, like when everything was hurting and I hadn't taken those scans yet, my brain wanted to say, oh, it's in your bone, I don't know that. That's one of the reasons I didn't want the scan. But that kind of keeps it real. And the other thing is WW. So WW is wait and watch, which is another way to look at it from a spiritual perspective, is patience and impermanence. So when something arises, let's say I have pain in my back, and I'm thinking, oh, it's gone to my bone. I don't know that, so I have to just watch it and be present with it. Because what I'll notice is it changes. Pain teaches you this all the time. It's morphing all the time. So that allows you to be with whatever it is and report more accurately than go screaming, So that way you get more information. So those are two really important things that have helped me kind of stay mindful and stay in the moment and not freak out with information that may or may not be real.
And the value of that tap cloud is that when you tap, then I have the trends as well. Because we do have a protective tendency to say, oh, it'll go away. And when we can report in and keep a log and not ruminate over it, but just tap and it's gone, my team gets the log. We can see the chart. We can see that things aren't going away, or they're getting worse, or they're getting better, and we can see those patterns. And again, that helps inform the decisions that we make, and I think creates a better approach to care. So I think what we should wrap with is really where this all comes to for us, and speak for us, is that both of us come to the work that we do seeing ourselves as spiritual beings having physical experience. We're not physical beings having a spiritual experience, it's actually the other way around. So I'd encourage you just for a moment here, just if you close your eyes and think to yourself, I wonder what my next thought will be. Who is it that asks that question? And who is it that is the observer? That's the metacognition. That is the spiritual self, the observer. And that is the place that we really want to grow. And this incredible experience with this incredible woman has been, for me, my classroom. One of my greatest teachers is being mutually vulnerable, open, eager, knowing this is bigger than either one of us.
Well, I just have to say thank you. I don't think I could definitely not do this without you there.
We're very grateful.
Yeah. Sometimes I can't wait to get to the tap card.
Excuse me, like blowing my microphone. And so, you know, our wish for you, our intention before we open this to questions is that you advocate for what it is that you need and for those that you love, that you're willing to be bold, you're willing to ask. You've heard us talk about how important it is, body, mind, and spirit, to attend to those things, to learn yourself so that you can recognize when things aren't right, and to find people in healthcare, because I'm not the only one. In fact, there's a great one in Atlanta.
Yes.
And there's more and more everywhere. There's many in Chicago. We are very blessed. Palliative medicine actually started at Northwestern in the early 90s as part of the AIDS epidemic. We didn't know what we were creating, but that's where it started, and has grown, and there's over 5,000 people, physicians who are certified, and many, many nurses and social workers now as well. Chaplaincy doesn't yet have its own training per se, but is an active part of the team as are other therapists.
Martha, I think that it's important maybe that you make a distinction, because I have run into people who think palliative and hospice are one. Like, you have to be dying to use palliative care. Maybe
It's a really good point. So, and there have been some missteps that we've made in this trajectory around this specialty that's kind of reinforced that misconception. So hospice was this idea of caring for seriously ill people at the end of life. And hospice is not just a philosophy of care, a team-based philosophy, but it's also an insurance benefit. And we kind of, when we have an insurance benefit, we kind of drift towards what gets paid for. And in order to be eligible to use hospice, you have to be in the final months of your life. 2 physicians have to say that your prognosis is likely 6 months or less. So hospice is a form of palliative care, but it's really for a certain group of people who are eligible to use an insurance benefit. The cool thing nowadays is that you can go in and out of that benefit, because a lot of people who use hospice care get better with great care, and they graduate. I had one gal who was so excited to graduate, she had photos taken, with a mortarboard and the whole thing. So it's a wonderful supportive service, but it is also an insurance benefit. All that is hospice is palliative care, but all that is palliative care is not hospice. So what was realized even in the 70s is this idea of team-based whole person care made a difference for people and could be applied much earlier. And that was really championed by an oncology surgeon named Dr. Bal Fremont at McGill University in Montreal. Bal is the one who coined the phrase palliative care or palliative medicine. And then it came to the US in the 90s, really. Bal helped us champion this growth so that we then at Northwestern, as one of the first, decided we were going to make it a medical subspecialty. And the reason being, when you're a medical subspecialty, every medical student has to spend time with you. And you could start to influence the culture. And we really saw it not just as you need to know how to care for really seriously ill people, but we wanted to reinforce this body, mind, spirit approach to healthcare. So palliative care has application for anyone who has a serious illness, irrespective of the expected outcome. Anyone who's had a serious illness can benefit from team-based whole person care. So what has been exciting is, as the specialty has grown, the research has demonstrated this. Jennifer Tamel and Vicki Jackson, 2 colleagues in Boston, did a study with advanced lung cancer patients. One group got standard oncology care, the other group got oncology care, plus they saw the palliative team when they came to clinic. And the group that had palliative care support at the time of their diagnosis of advanced disease had better symptom management, higher quality of life on validated scales, more completion of advanced care planning. They tended to stop chemotherapy earlier, and they lived 2.7 months longer on average than the other group. And we continue to see this, we see this in hospice too, that great whole person care helps people live well and live longer. Duh. When you take care of a person, body, mind, and spirit, and support their life energy, they're going to do better. So this idea of integrating palliative competencies and a team at the time of diagnosis is really what we're pushing for, and that's what the work is currently at Lake Forest.
So when I started, and we'll maybe should open this up after this, but when I started 40 years ago, plus years ago, that was literally chasing death, you know, trying. And now I feel like I'm just living with cancer. The death is not in the equation. I'm not dying. I mean, I will, and this may be how I die, but that is not the focus at all. And it was such the focus of traditional medicine some 40 plus years ago.
Yeah.
There was a huge difference. And we, as patients, need to advocate. We have a right. We need to find our voice, listen to our bodies, know what we need, understand what's happening, and have the courage to speak it out. Because there are people out there that will hear you and help you in ways that aren't necessarily prescribed and traditional.
Creating that space. So we want to open it up to questions. See some familiar faces out there. So we're going to
Me
need
too.
help because we can't really see.
There's one right there.
I have a question about the team structure. Why that is such an important component. I mean, I understand you have different physical systems, and you might use a kidney special, and you might use an osteopath, but is there something more to the team?
So the interdisciplinary team is really the hallmark of palliative care versus a multidisciplinary team. So medicine and medical care in the U.S. in particular is multidisciplinary. Wedges of a pie. Everybody comes in, they've got we break you into your body systems, and then we assign a different doctor to every one of them. And then they never talk to each other. And they come in and they report on your kidneys and your lungs and your heart and your peeing, your breathing, but they don't integrate.
The whole self.
So interdisciplinary, the best model for that is the hand. Each individual finger works better if they work together. So this idea of a little bit of role blurring, that the physician may be the one that starts the spiritual screening, and then the spiritual care person comes in to do a spiritual assessment. Or the nurse might touch on some of the social aspects of suffering, and the social worker gets involved to help with the counseling. So the idea that we are multidimensional, and people in different disciplines and specialties of an interdisciplinary team can really enhance the care. So it's critical that the team is driven by the needs of the individual, not inflicted on them. Oh, you have to have a chaplain. Oh, you have to have a social. No. We need to assess what your needs are, and that team can be very dynamic to help with your well-being.
And I have a separate team that participates with Martha. I have an acupuncturist, a physician of Chinese medicine, that I have Chinese herbs, and I have a homeopathic practitioner that uses homeopathy. I like very subtle energies for healing. So, but I report everything to Martha. She learns from me, and so it's all working together. But again, you can advocate for yourself. You can create your own teams with your partners.
She's the center of the team with her family.
Right.
Oh, what bright shining stars you are in our universe. Thank you. I have an 88-year-old friend who has some orthopedic issues and severe depression, and he's been pursuing a medical marijuana license or certification in Chicago. And I cannot believe how complicated it is to do that. It's taking him 3 months, 3 doctor visits, totally about $1,000 invested in this, but he's had some incredibly positive experiences at the dispensaries. So it's very hopeful, and I think this is something we really need to go more exposure about, and how valuable it is, and I would love to get a reporter to interview you.
Absolutely.
Do
It does
that?
take
Any in
3
the
months.
audience?
Joe,
Anybody
speak.
connected?
We actually have 2 experts in that in our audience today. So, Mr. Friedman, do you want to stand up and just?
Sure.
Somebody might have a question.
The process right now is broken. The state of Illinois, the Department of Public Health, I understand that there's new people on board, and when the program first began, it was taking about 30 days, which is still a long time when you're in pain to get a product or a therapy that could be helpful. Right now, when you submit your application to get a medical cannabis card, it can take anywhere, we're telling patients right now, it can take anywhere up to 45 to 90 days. And what's even more concerning is there is a particular form for terminally ill patients. And that form doesn't require the fingerprinting and and fees. And basically, it's all on one form that the doctor signs off. This patient has 6 months or less to live. The caregiver can sign on that, and the patient signs on that. It goes to the state, and then they'll get their card within 2 weeks, which is still kind of a long period of time if you're terminally ill. But I've heard that that is taking up to a month now. So if these patients that have 6 months left to live, 1/5 of their life is spent waiting for their medical cannabis card. So I think the best thing to do is, contact, Channel 2, Channel 5, Channel 9, and just, make this an issue, because it's not the right way to run this program.
We desperately need more research, and if we had more structure around it and could actually start to capture data and outcomes and things like that, it could be very, very powerful, because there's much that we need to know about this, and for me, learning kind of by the seat of my pants with my great teacher here has been really important, but it's really important that we get some of this training in our training, and that we have seminars, and that there is an ongoing research.
There's also research that has shown that marijuana, THC, and CBD shrinks tumors. And again, I can't account for why right now I'm doing better. I kind of had a medical crises, and we went on prednisone. We went on prednisone.
I felt it
And it
too.
reversed this terrible downhill thing we were doing. I'm not sure, but I am believing that it's also shrinking tumors. That thought, letting that thought in, because why not? And that is definitely one of the benefits.
Been back. Look, it's
Oh, here's one.
Mine is rather long-winded. Kind of a statement and a question at the same time. So I typically go out and I meet with patients and families and talk to them about palliative care and hospice services and explain to them what the differences are. And nobody knows what the differences are. Believe me, they don't. And when they realize what the differences are, they always say to me, why did we not know about this sooner?
Yeah, I've heard that for
So
30 years.
it's a horrible thing to hear. And, I always tell them that you are our advocates. This is a wonderful service that you're, starting, and we're here to help you. But how can we get it across to the doctors that we're not interfering with their care? We're partnering with them to help their patients. And, we have maybe one practice of oncologists that recommend palliative care the second their patients are diagnosed with cancer. And I praise them for that. But why can't all the other oncologists or pulmonologists or cardiologists do that? I mean, what do we need to do to encourage them to partnership with palliative care services?
So I would say, with a perspective of 30 years, it's amazingly better than it was when I was Martha Morphine in 1989. But we do have a lot of work to do, and it's generational in some ways. So the fellow or the specialty's only 11 years old. The research, in terms of really substantive research, is probably less than 7 years old. The big mistake, honestly, or kind of in hindsight, one aspect of our work in palliative care that we realized negative repercussions is where we started. So in the year 1999, we received a grant from the Robert Wood Johnson Foundation to start palliative care initiatives in hospitals all over the United States. And the Center for Advancement of Palliative Care was born, CAPC. And so we worked in ICUs and hospitals across the country to grow palliative care. And that's where most physicians train, is in a hospital. And guess what happens? Of the patients that you care for with palliative care in a hospital, 80% of them die in the hospital. And so the physicians in training began to associate palliative care with end of life.
Oh.
In hindsight, now our efforts are to look at palliative care not about where the person is, but who the person is and what they need. So we're rewriting our clinical practice guidelines, even as we speak, what's called the National Consensus Project for Quality Palliative Care. Dr. Betty, she's PhD RN, and myself are co-chairing this project to rewrite these clinical practice guidelines, and they apply to the person, not the setting. So it's about who that person is and what they need, irrespective of the setting where they receive care. And as we push palliative care into this continuum, this idea of meeting people early in ambulatory settings and seeing them throughout the continuum, we will start to change that. But that is more recent. So that really, the efforts around that didn't start until the 20-teens to be more focused on extending into ambulatory settings and extending into really home-based palliative care as well. So it's frustrating, I hear you. And when people say they're not ready for palliative care, I just think, how can you not be ready?
Are you alive?
How can you not be
Do you
ready
ever
for whole
suffer?
person care? One of the great leaders in this field is a gentleman, Dr. Ira Byock, and he's currently at the Providence System in California. And Ira has taken it to a whole new level, where the idea is not about just serious illness, but whole person care. So that changing the culture of a healthcare system to focus on who is the person, what's important to them, how do they make healthcare decisions, and then what's their diagnosis. And training everybody in that philosophy. So that's what he sees is where we need to take this. And then people would be like, well, of course I use palliative. Duh, that's just good medicine.
Right.
So from our mouths to God's ears, within the next 5 years, let's go for it, okay?
I agree. It's also up to us.
I'm sorry.
I was just going to say, we're doing this to educate and share. And now, you all go and do that's part of this kind of open-ended, we're a vessel. Because hospitals are no place for sick people.
No.
Palliative care keeps us out of them. And that's the difference as far as I can see. They meet you where you are. It's not to have to be in the hospital with all these different lines going into you. Mm-hmm. It's to keep you away, keep you healthy.
And I think we see a lot of less people returning to the hospital.
Yes.
If on discharge, they would have that palliative care.
That's
in
right,
place.
or integrating so they don't need to be hospitalized. Now, the big challenge is getting it financed, right? And there's a lot of work being done to figure out better ways to support palliative care with a financial model that supports the team. So when we, Midwest Care Center years ago, started doing home-based palliative care in 1998, can you imagine that? Sending a doctor and nurse all over the place to see people at home. We could cover maybe 60% of our cost. 60% of our cost. There's no margin whatsoever. And so it's I, over the years, saw the growth and destruction of 3 different home-based palliative care programs because they weren't sustainable. And the other problem was we over-medicalized them because the entities that would get reimbursed were physicians and nurse practitioners.
Traditional
And so
medicine.
then we'd send them, even though the issue was psychosocial spiritual. So what we've been working on are models to figure out how to support these teams with what are called per member per month payments. So Aspire Health, which is a company in At Nashville, over the last 3 years, has worked on this model with analytics and computer programs to identify the population that would benefit, and has served over 20,000 people last year alone. It's the largest provider of home-based palliative care in the country. Now, those people have very high mortality, and it's unfortunate they have to be in a managed care plan in order to get that type of support. But what Aspire has done for us is it's helped demonstrate what a payment mechanism could look like. So at the academy level, we are submitting, and I ask for all your positive prayers. We are submitting to PTAC next week our advanced payment model for palliative care coming out of the American Academy of Hospice and Palliative Medicine, and hoping that they give us the nod so we can pilot this. Because what we want to see is that the team is supported to provide this care, and that, again, the care is about what the person needs, not about what gets paid for. So these are some of the exciting things that are happening, even as we speak, and we just seek your positive intention around that.
Yes.
We have a question.
We need a mic over
Throw
here.
the mic over.
Oh,
Right
okay,
here.
1 second.
Hi.
We have-
Hi, how are you? I'm glad I came tonight because I've learned a lot. I have a sister who, in the late 80s, had stage 4 ovarian cancer and survived. She now has breast cancer again, or has breast cancer, and is going through the traditional, which I definitely will talk to her about this. And my original question was really, since palliative care is for the serious, illnesses, when do you, and you kind of answered it, when do you see a balance between, we'll say aggregate patient medicine and then moving people into a specific side? So even people, you've said it before, even people who are sick right now could use palliative care. It might not be serious, but it's something, looking at the individual patient.
So the idea is that palliative care integrates with the healthcare team that's already present, doesn't displace, doesn't take over, and it's not a place like hospice. It's not a place that you go. It's an additional service and an extra layer of support. Our goal is that every clinician would have basic palliative competencies, know how to assess and manage pain, know how to have serious illness conversations, know how to shepherd someone to create an advanced care planning document, basics. And then you'd use specialty level as needed, but the team would be in response to the individual. So you would add in those services, and the intensity of how much needs to be added would depend on what that person needs. That's the goal.
So it's really balancing.
Balancing, yeah, integrating extra support as is needed for the individual and their family.
Can I just underline what I keep hearing, and I want to make sure everybody, this is so important as a patient, that you're your own advocate. They only can help you as much as you can tell them what you need.
Yeah.
And self-awareness is a huge part of being able to advocate what you need. I can tell a little story on myself that's kind of a joke, but it's not funny. But it was a real struggle for me because, so I'm an only child, and my mother was raised Christian Scientist, which believes that the body is an illusion. And my father was an agnostic and a hypochondriac. So I had no body, and it hurt all the time. But when I had cancer, I was so confused.
Yeah.
Like I couldn't separate out, you're crazy, that's not a problem. I would dismiss myself because of this kind of mixed message I grew up in. So, it was no surprise that I showed up with my phone book of, how to do visualization, because I had to find a way to navigate through my own stuff to be able to advocate for myself. So that's just my story. We all have our stories, but what was your model for health? What was your model for using your voice to speak for what you need? What are the voices in your head saying you're whining too much? Don't ask for help. Those are really important to say. I said to you, I think one of our phone conversations, to be honest, I said, you have to tell me, do I really have cancer? Is it real? I was just like making myself crazy. So I just wanted to make that point.
Yeah, yeah.
question. I've always thought of palliative care just for cancer. That's been kind of my road that I've walked down. I was just wondering, I have a son that had a traumatic brain injury, and he experiences pain. And is it available, palliative care, for somebody who is experiencing pain, actually as a result of spasticity? Is there a road for him also? I don't know.
So palliative care doesn't typically be, they're not usually the sole providers within a chronic non-malignant pain scenario, because those folks benefit from a holistic team that involves physical medicine rehab, neurology, physical therapy, but they may have input. So you're right that palliative care and oncology are hand in glove, because we have data, we see it's easier to identify the patient population, et cetera. And palliative care is now starting to show impact in things like advanced kidney disease, pulmonary disease, heart disease, and some of the neurologic syndromes. We can help with the chronic pain scenario, absolutely, because that's a serious life-changing illness. Typically wouldn't be the ongoing managing service, simply because of how much we are expected to do in other domains, but can give input. And that voice, that advocacy to say this is a person, and this is what's important to him and his family and how they make decisions, even that, to get the construct around how care will be delivered and what the plan is, and to find a really good primary care or treating neurologist who will stay dedicated through that time is going to be critical.
You know, I have one doctor who's a physiatrist who wants to put the whole team together.
Yep.
But the whole team will not come on board.
Yeah.
So it's very interesting, but that's the beginning.
That's and it's that advocate, and God love that person, because and physical medicine rehab, physiatry is an incredible field. Incredible, and we are blessed in Chicago with the Shirley Ryan Ability Lab. That is, I must say, the CEO is my old intern. I'm so proud of her. I knew her when. It's a phenomenal place, and that idea of really therapeutic involvement, physical therapy, whole person. I hope that my next doctor who joins our team is a physical medicine rehab palliative care doc. That's what yeah, okay, good, all right.
We have time for one more question.
So if medical aid in dying were legal in Illinois, would you consider that an aspect of palliative care?
Actually, no. So we don't speak against it necessarily, because we advocate for what the person says is important. But palliative care physicians are not the group that advocate for being the ones to facilitate death, because we feel very passionately about facilitating life. And we believe that good palliative care, early and frequent support, makes the need to end life often not necessary. And that sacredness of living well and living until you die is really what we pursue. So we have separated ourselves from saying we are not the docs that do the aid in dying. We don't expedite death. We're not the death panels. We're about living well, as long as you can, in the fullness of who you are, with the people that you love around you. And that's what we are dedicated to. We did it.
I want to thank both of you. It's been great, and we'll have you back again next year.
And bank on being here.
Another talk.
Yep.
Thank you for all.